Welcome, ladies and gentlemen, to today's tutorial. Today we want to look at the brachial plexus. Now this plexus is nothing but a plexus of nerves, which supply the upper limb as well as the shoulder and the pectoral regions. Now, they are organized into what we call roots. Roots will give rise to trunks. Trunks, divide into anterior and posterior divisions. These anterior and posterior divisions will organize themselves into cores, and then finally giving rise to the terminal branches. So that's the brachial plexus organization. Now, roots and trunks are actually found in the posterior triangle of the neck. The divisions and cores, are actually found behind the clavicle, posterior to the clavicle. And then when the branches find themselves inferior or below the clavicle, actually in the axilla, the armpit, that's where they are. Now, for the roots, what happens is that we have what we call C5, C6, C7, C8, and T1 ventral rami. Actually, the ventral rami of C5 to T1 spinal nerves. Now, what happens is that there could be prefixation, where what happens is that it will begin actually from C4, and therefore it's really T1. And there could also be what we call postfixation, which will actually start from C6, it's really C5, and ending at T2. So these variations can take place. But generally, in normal anatomy, this is what we have. So the ventral rami of C5 to T1. Now, C5 and C6 converge to give us what we call the upper trunk. C8 and T1 will converge to give us the lower trunk. Now C7 stays alone to give us the middle trunk. Now, what happens is that these trunks will divide, each of them will divide into an anterior division and posterior division. So let's say this anterior division of upper trunk, posterior division of upper trunk, anterior division of middle trunk, posterior division of middle trunk, anterior division of lower trunk, and then posterior division of lower trunk. So that's how the divisions happen. Now, in formation of the cores, the anterior division of upper trunk as well as the anterior division of middle trunk will unite. Okay, they will unite to form what we call the lateral cord. Now we are still left with another anterior division. Now this anterior division of this lower trunk stays alone and becomes the medial cord. Now we are left with the posterior divisions of all these. So the posterior division of upper trunk, posterior division of middle trunk, as well as posterior division of lower trunk will give us the posterior cord. This nomenclature is has a lot of their relation with what we call the axial nerve. Actually, the first and second part of the axial nerve. Now, these cords will further give the terminal branches. Lateral cord will give us 3, posterior cord will give us 4, and the medial cord giving us 5. 3, 4, 5 in the order. 3, 4, 5. Now, what happens is that we can have a nerve, coming directly from the C5 root value, and that nerve is known as dorsal scapular nerve. So dorsal scapular nerve, its root value is C5, coming directly from C5 ventral ramus. And then we have another nerve, this time around, taken from what we call C5 root, C6 root, as well as C7 root. This nerve is known as long thoracic nerve. This long thoracic nerve actually supplies what we call the serratus anterior muscle. Now, if this nerve becomes injured and therefore can cause weakness of this, serratus anterior muscle, what happens is that clinically is diagnosed by asking the patient to push, against a stationary wall like this, And what happens is that if the patient continues to push, what happens is that you see that the medial border as well as the inferior angle of the scapula or wing, will be more evident, will become more pronounced. That's winging of the scapula. Now, for the trunks, we have two nerves coming from this area, and actually it's coming from only the upper trunk. So coming from only the upper trunk. So like this and this way. So let's say nerve to subclavius muscle. So one of the nerves is nerve to subclavius muscle, and then we also have the suprascapular nerve. Now, what happens is that at this point we have a point known as Ebb's point. That is the Ebb's point. For the Ebb's point, 6 nerves actually meet here or converge here, and they are coming from the C5 root, C6 roots, okay, anterior division and posterior division of upper trunk, as well as nerve to subclavius and then suprascapular nerve. Actually, these one. Now you get to know that the nerve to subclavius, muscle will actually be supplied, will give supply to subclavius muscle. Suprascapular nerve will supply the supraspinatus and then the infraspinatus muscle. And for the dorsal scapular nerve, yes, if you visit my video that I did on the scapula, you get to know that we have what we call, the levator scapulae muscle. Apart from the levator scapulae muscle, we have rhomboideus, major and minor, all getting their nerve supply from the dorsal scapular nerve. So that is what we have here. Now, for this point, then there could be an injury to the upper trunk, which usually affect the C5, C6, and that is what we call Ebb's palsy. And that one is caused when there's lower traction, at the neck region, lower traction, like if you are an intern or let's say a house officer who is not really qualified, I believe that's one. So what we see is that there could be Ebb's palsy, where the upper trunk will be affected, and in such case, what are the clinical manifestations? They present what we call policeman tip deformity, or waiter's tip deformity, or the porter's tip deformity, where essentially the arm is adducted to the body, and then there is what we call pronation. There's pronation, with the essentially the upper limb turning into medial rotation or internal rotation. But therefore, what will be the movement which will be lost? The movement is presented with the mnemonic FICE. FICE will help us remember the movement which is lost. And F is for what we call flexion. E is for abduction. E is for external rotation, or simply, lateral rotation, and then S is for supination. Now, if flexion is lost, okay, you can't flex, flexion is lost, then it means it is extended this way. So extension, is happening, but flexion you can't flex. And usually the muscles which are mainly for flexion, which will be affected, the brachialis muscle and then the biceps brachii muscle. For abduction, it means the muscle is what adducted, turned within, and usually the muscle that is often affected will be what's the name? Will be the now for adduction, it means that it's adducted closer to the body. Therefore, the muscles which will be affected will be the supraspinatus, for 0 to 15 degrees, and then the middle fibers of the deltoid muscle will be affected. For the external rotation, which is also affected, it means that the subscapularis, will also be affected. In fact, the subscapularis is helping you to medially rotate. Therefore, external rotation will be by the teres minor as well as the infraspinatus muscles will be affected. For the supination, the supinator muscle as well as even the biceps brachii muscle being affected. So that is what we find with the F part, that's the clinical presentation. Now, there is another issue which can happen with the lower trunk, and that's known as Klumpke's palsy. Klumpke's palsy. And with Klumpke's palsy, usually when there's upper traction, at the neck or at the shoulder area, then it can result in, let's say, falling from a tree and then hanging onto the tree so tightly, then there could be, affect this area. Now, if it affects the sympathetic fibers of the cervical, nerves, cervical chain, what happens is that it results in what we call Horner's syndrome. Horner's syndrome. Now, this Horner's syndrome actually presents with what we call Myiosis, resulting in what we call loss of spinociliary or ciliospinal reflex, resulting in anhidrosis, yes, it will result in what we call exophthalmos, and results in some twists. And meiosis is actually a constriction of the pupil, loss of spinal ciliary reflex or ciliospinal reflex. Usually when there's a stroke around this area, what happens is that it should result in mydrosis, dilatation of the pupil, but that one is lost. Anhidrosis, difficulty in sweating or even lack of sweating, and exophthalmos, sunken of the eyeballs with ptosis, having the upper eyelids, being lazy, twists. So that is what usually will happen in most of the cases of Klumpke's palsy. Now, for the Klumpke's palsy, it can, result in, because the lower trunk is actually supplying, the intrinsic muscles of the hand eventually, and therefore when that happens, it results in what you call hip thumb deformity, or let's say the clap fingers of clap hand, and that one is going to happen because we know the lumbricals are supposed to help in what we call it flexion at the metacarpophalangeal joint and extension at both proximal and distal interphalangeal joints. And so when that happens, then it results in the opposite. So it means the metacarpophalangeal joints become extended with the interphalangeal joints being flexed, and this results in what we call a claw hand. So please let you know that. So now let's see, we are done with this. Now let's look at the various divisions, terminal divisions. We said that the lateral cord is going to give us 3 branches, and simply by this mnemonic LML. And L is for lateral pectoral nerve, M is musculocutaneous nerve. The lateral pectoral nerve will actually supply the pectoralis major. Musculocutaneous nerve will supply the BBC muscles, in the anterior compartment of the arm. Bicep brachialis muscle, and then the coracobrachialis muscle. So now, after supplying these, what happens is that it becomes the lateral, cutaneous nerve, of the forearm. Now, the next one that we find is that we also have, there's another L, that's the lateral root of, the median nerve. Lateral root of the median nerve. Now get to know that all these, nerves coming from the lateral cord have the root value C5, C6, and C7. So remember that they are paired. So from the C5, C6, C7, we'll supply these ones. Now, how about the medial cord. Now we said that medial cord is going to give us 5, and it is simply by this mnemonic M for U. So there are 4 M's. So first M is the medial, that's slash out. So this is medial pectoral nerve. Medial pectoral nerve. And you go to another M, that's the medial cutaneous nerve of the arm. Okay, there will also be what we call medial cutaneous nerve of the forearm, and there will also be what we call the medial cord of the median nerve, and then there will also be this U, that is the ulnar nerve. Now, all these ones, okay, will be supplied by what we call the C8 and T1. This one has taken the first three, C8 and T1, with the exception of, the ulnar nerve, which gets a communicating branch from C7. So ulnar nerve is supplied actually by C7. Its root value will be C7, C8, and T1. That's what we have. Medial pectoral nerve will, of course, supply the pectoralis major. Medial and natural medial, cutaneous nerve of arm and forearm will supply, the skin, the medial aspect of the skin, gives sensation to the medial aspect of the skin of the arm and forearm. And then medial cord, as well as lateral, will contribute to form what we call the median nerve. Yes, of course, we know the ulnar nerve will actually supply most of, the flexus of the anterior compartment of forearm. That's what we find. Now, the next one which is the posterior cord. We said it's having 4 branches simply by this mnemonic star. So once you remember star, there's a suprascapular nerve, and actually suprascapular nerve, will have what we call the upper division of the superior part, and then the lower part of the suprascapular nerve. And then, T is for thoracodorsal nerve, or simply it's nerve to latissimus dorsi, nerve to latissimus dorsi. And then there is an A, which is the axillary nerve. And then there is an R, which is radial nerve. Now, what happens is that for the R root values, it begins from C5, so suprascapular nerve C5, C6. Thoracodorsal nerve actually from C5, C6, and C7. Nerve to latissimus dorsi is, the same, that's the same, so that's C5, C6, C7, and then the axillary nerve actually, C5, C6, and then radial nerve having, the root value for all being from C5 to T1, ventral root values. Now, what happens is that the suprascapular nerve, the upper part, will supply, the suprascapular, supraspinatus muscle. That's what we will have. Suprascapular nerve will supply you have the upper and the lower portion. Then the thoracodorsal nerve, or nerve to latissimus dorsi, as the name suggests. The axillary nerve will actually supply the deltoid muscle, as well as the teres minor muscle. The radial nerve supply, muscles of the posterior compartment of the forearm, as well as the hand. So, briefly, this has been the the brachial plexus. That one thing that we have to appreciate, which is of clinical importance, is the suprascapular nerve. And suprascapular nerve, we know of supraspinatus muscle, which is for initiation of abduction. And therefore, when there's injury to this nerve, then it means you can't initiate abduction. That's 0 to 15 degrees. But if someone helps you and raises your upper limb this way, then you can actually continue with the abduction of the upper limb. Ladies and gentlemen, this is a quick tutorial on the brachial plexus. Thank you.